Okay, Chapter 47, Part 1, Infections of the Skin in the Pediatric Population. Let's take a look at some pediatric differences of the integumentary system. If you look here on the slide, newborns, skin's very thin, the epidermis is loosely bound to the dermis. Friction can cause separation of layers with blistering. Eccrine sweat glands function, produce sweat in response to heat and emotional stimuli. Apocrine sweat glands are small and non-functional, and there's less melanin that's present at birth, so the skin appears lighter colored. Adolescence, skin thickens, epidermis and dermis are tightly bound, increasing resistance to infection and irritation. Eccrine sweat glands achieve full function. After puberty, males sweat more than females. Apocrine sweat glands mature during puberty. Melanin is at adult levels, determining skin color and serving as a shield against ultraviolet radiation. Let's talk a few seconds about bacterial infections. Look at table 47-2 on page 1499 of your textbook. You can see the difference impetigo, scalded skin syndrome, pyoderma, folliculitis. Nursing goal, you want to prevent spread of infection and prevent complications. Especially for your MRSA interventions, you want to make sure you separate washcloths and towels. You want to wash cloths in clothes in hot water. You may need to provide a chlorine bath 1 to 2 times a week. And you're going to provide education about Bactroban to the NARS, the family members, BID for 2 to 4 weeks to prevent reinfection. When you talk about viral infections, the most communicable diseases of childhood produce characteristic rashes such as rubeola, rubella, and chickenpox. Look at table 33-2 on pages 966 to 972 of your textbook. Less common ones are verruca, herpes simplex types 1 and 2, varicella zoster, molluscum contagiosum. You want to look at table 47-3 on page 1500 of your textbook. Looking at dermatophytosis, that's a fungal infections. The fungi invade the stratum corneum, such as hairs and nails. Fungi are larger than the bacteria, such as you would have, for an example, a ringworm is caused by a group of filamentous fungi. Transmission from person to person or from infected animal to human. Examples are Tinea capitis, Tinea corporis, Tinea pedis, and Candidus. Tinea capitis can cause alopecia. Tinea corpus, there's an oval, scaly, inflamed ring with clear center. Tinea pedis, lesions are between toes, on the instep or soles, could be parietic. Tinea cruris, also referred to as jock itch. Look at table 47-4 on page 1501 of your textbook. Let's talk about dermatitis. More than half of dermatologic issues in children are forms of dermatitis. There are 4 common types of dermatitis in children. There's contact, there's diaper, there's seborrheic, and there's atopic. Contact dermatitis occurs in response to contact with an allergen to an irritant. Common triggers are soaps, detergents, fabric softeners, bleach, lotions, urine, stool, poison ivy, poison oak, lanolin, neomycin, rubber, chemicals in shoe leather, nickel, fragrances, and latex. Treatment, you want to figure out the cause and remove it, and then steroids may be helpful to speed up healing. When reviewing diaper dermatitis, skin is irritated by prolonged contact with urine, feces, retained laundry soaps, and friction. And I can also tell you it could be brands and different types of diapers that can cause diaper dermatitis. May be seen in response to addition of solid foods, feeding, chemicals, contact with household substances. There's a beefy red rash. It can be indicative of a candida infection. Prevented by frequent diaper changes with meticulous skin care. You want to treat with water, impermeable barrier, or nystatin cream. You want to be sure to teach parents to allow the area to dry after cleansing before applying skin barrier. Otherwise, it will not stick and it will defeat the purpose of it. Now, when talking about atopic eczema, it's chronic, it's a relapsing superficial inflammatory response that causes intense itching, affects about 17% of children. It is a risk factor for developing asthma and allergic rhinitis. It's associated with food allergies or intolerances, and it seems to be a genetic predisposition with the immune system trigger. Another disorder is eczema. Acute eczema is characterized by patches of vesicles, exudate, and crust. Subacute is characterized by scaling, erythema, and excoriation. Patches may actually weep. Chronic is characterized by darkened, thickened skin with prominent skin lines, excoriation, the dryness, and the scaling. Uh, Treatment only. There is no cure. Goals, we want to hydrate and lubricate the skin. We want to reduce itching. We want to minimize inflammatory changes to try to eliminate the triggers and prevent secondary infections. Could use topical steroids to achieve quick control. So for parent teaching, you're going to teach them ointments should be completely washed off between applications. Cortisone creams should be avoided because they do not resolve the underlying cause. You're going to teach them how to apply topical medications. You're going to teach them that it's best absorbed after a warm bath. You need to teach them to apply by stroking in direction of hair growth. You want them to use the proper amount of ointment. You may also teach them that elbow restraints can prevent an infant from scratching while allowing them freedom of movement. I've not seen this in many cases. And then topical steroids should not be used when a viral infection is present. Let's talk about seborrheic dermatitis, also known as cradle cap. Crusty, sometimes yellow scales on the scalp. It's caused from overgrowth of yeast. Treatment is usually an emollient on the scalp for 20 minutes to loosen up the scales, then brush them off and wash the hair. Sometimes they may recommend a tar-containing shampoo, and if they do, you want to teach them to make sure that they protect the baby's eyes or children's eyes, because this could cause irritant to the eyes if not be completely harmful. Let's talk about acne. It's a chronic inflammation of pilosebaceous hair follicles on the face and the trunk, thought to be triggered by puberty. Increased androgen production causes sebaceous glands to increase production of sebum. Sebum mixes with the keratinocytes and causes clumping, which blocks the follicular canal. The sebum becomes breeding ground for bacteria, causing inflammatory response instead of infectious. Papules and pustules then develop. So topical treatment can include catalytics such as benzoyl peroxide. Should be used in the morning. They may recommend antibiotics or retinoids such as retinoids. Should be applied at night because the drug stability is affected by light, and you want to use it over entire face, not just spot treatment. And then, of course, there's also oral treatment used, such as antibiotics. Some examples are tetracyclines. They, when a patient takes tetracyclines, you need to teach them to stay out of the sun. They'll need to take 6 to 8 weeks for improvement. They'll combine it with peroxide and topical retinoid to prevent antibiotic resistance. And then, of course, we have Accutane. They'll, if it's female, they'll need a monthly pregnancy test. They must use contraception. They need to take with food to increase absorption. They want to monitor cholesterol and triglycerides, liver function. And remember, it is a tetragenic. And then, of course, oral contraceptives, you want them to take them at the same time every day. So make sure they look at the package insert. This concludes Chapter 47, Part 1, Integumentary Dysfunction in Pediatric Population.